Internal and external influences affect the GI tract. This could be food intake, any bacterial influences, psychological stress, and so on. The GI tract is vulnerable to infections and inflammation due to constant exposure to the external environment through ingestion of food and water. There can also be issues with an individual's own resident bacteria. So these are going to be some of the things we're going to be talking about: appendicitis, paralytic ileus, obstructions, cancer, and ostomies. So first we'll talk about appendicitis, which is going to be an inflammation of the appendix. So the manifestations of this is going to be pain. Initially, the pain is going to be mild and diffuse abdominal, so that means kind of all over. Over the next 4 hours, it's going to intensify, and then it's going to localize into the right lower quadrant. It's going to be aggravated by moving, walking, or coughing. These patients are also going to be febrile. They're going to have a low-grade temperature, anorexia, nausea, and vomiting. Also, think about during your assessment what you would be doing with palpation. So on palpation, the localized and rebound tenderness is noted at McBurney's point. So the rebound tenderness, if you remember that from your assessment class, that's demonstrated by pain relief with direct palpation at McBurney's point, followed by intense pain upon release of the pressure. This is going to be harder to assess in older adults due to vague or less accurate symptoms, as well as during pregnancy. Complications. So an acutely inflamed appendix can perforate within about 24 hours. So rapid diagnosis and treatment is very important. Sometimes if there's a really urgent case, they're going to limit any type of pre-op diagnosis and just rush them to surgery if an appendicitis is evident with an impending rupture. So diagnostics for this are going to be abdominal ultrasound or CAT scan. That's going to be the most effective diagnostic. Abdominal x-rays, IV pyelogram, and that's to rule out acute polynephritis, and that is a kidney or renal pelvis infection. So UA to rule out UTI, a pelvic exam for females, and a CBC. They'd be looking for an elevated white count with an elevated band level. That's your immature WBC count again. So other complications from this can be, of course, the perforation, which can lead to peritonitis. They could have an abscess or even chronic appendicitis. And a chronic appendicitis is going to lead to chronic abdominal pain and recurrent acute attacks. And this is an example of a CT scan with contrast to look at the appendix here. So preoperatively with these patients, you're going to be prepping them for emergency surgery. So we've talked before about the different ways to prep individuals, and you would get the consent, make your patient NPO, and get your checklist done. Sometimes this happens so quickly that you have a lot of people working on this at the same time. You're going to be, again, prepping them for emergency surgery, and you have a limited time for any pre-op treatment because you do want to prevent rupture of that appendix. You're going to be starting IV fluids, and that's given preoperatively to help restore and maintain vascular volume and prevent electrolyte imbalances, especially if surgery is indicated. Antibiotic therapy, and that is repeated during surgery and continued for about 48 hours due to potential perforation within the first 24. Pain medications as needed, and then you're going to place a bag of ice over the right lower quadrant to help decrease inflammation in that area. So most of the time they're going to be doing a laparoscopic removal, and just like we talked with cholecystectomy with the removal of the gallbladder, they would also do a consent for this for the appendectomy to do it laparoscopically with a possible open procedure. So this is going to be the treatment of choice for an appendectomy, to do a laparoscopic procedure to remove the appendix. This is done with a laparoscope and about 3 puncture sites, or a laparotomy, which is going to be the surgical incision, and that's when the appendix is ruptured and they need to open it up. So this is going to be your puncture sites for the laparoscopic removal. The advantages of a laparoscope are going to be visualization of the appendix for a definitive diagnosis without an incision. They're also going to have shortened hospitalization post-op, decreased complications post-op, and recovery resumption of normal activities sooner. So it's going to be less disruptive to life. The disadvantages is the cost and the longer operative time. So surgery like this is much more expensive than an open. So they have a relatively new procedure too, called a needle appendectomy, and that's going to be a even longer operative time, but a lot less pain with a lot smaller incisions. The open, that again is going to be done if you have a ruptured appendix, and that allows for removal of contaminants in the peritoneal cavity and to allow for irrigation. So they're going to cleanse the abdominal cavity with normal saline to help rinse that off and give them a higher dose of antibiotics to help prevent peritonitis. And here is a really good picture of an inflamed appendix. I kind of wish it had some type of ruler next to it so you could see how big it is, because this looks pretty inflamed, but it's kind of hard to tell how swollen it is. So nursing diagnosis, there's going to be a risk for infection here. You want to monitor this patient's vitals, make sure that they're not febrile, assess your incision, so whether that be the puncture sites or an open incision, give them their antibiotics. They are a skip patient. Remember when we talked about that in the operative section? IV fluids until tolerating PO. So a lot of times these patients will also be progressed on their diet as tolerated, but you want to make sure that they're able to tolerate that before you shut off the fluids. And the order will generally state saline lock when tolerating PO. You're going to make sure that you control their pain. So you want their pain to be well controlled so they can get up and ambulate, use their incentive spirometer, deep breathe and cough. You won't have to do as much splinting with this one as you would with a cholecystectomy, but they're still going to have some incisional pain. So paralytic ileus. A lot of times this is what you're going to see after a surgery. So with a paralytic ileus, peristalsis is slowed or stopped by inflammation. Also, the intestines are asleep due to anesthetics. And what happens here is peristalsis fails to propel any type of intestinal contents, although there is no mechanical obstruction. So you're not going to see an obstruction here, it's just that it's asleep and not working. This is going to be most common after abdominal surgery. And when the intestine is obstructed, gas and fluid accumulates proximal to and within the obstructed segment, and that distends the bowel. Other causes for this can include vascular insufficiency, electrolyte imbalances like hypokalemia, and an inflammatory response such as peritonitis or sepsis. So manifestations, they kind of vary with paralytic ileus. So we can see that this particular person has quite a bit of abdominal distension. They look kind of pregnant. So they're going to have crampy or colicky pain. Think about how big this belly looks. So everything is going to back up. They're going to have some vomiting, diminished or absent bowel sounds, and some tenderness. So they're going to be pretty sore. Non-mechanical obstructions tend to have some pretty vague or diffuse symptoms, constant pain with significant abdominal distension, and they might have a pooling of secretions as well. So going by those manifestations, I want you to think about what could possibly be ordered for this patient. Do you think the physician is going to want them to eat? What type of diet would you anticipate being ordered? Remember, their bowel sounds are markedly hypoactive or even absent. And they're having pretty progressive abdominal distension as well. A lot of the interventions that are going to be done are going to be based off symptoms. So this patient is going to have a KUB, which is an abdominal x-ray that looks for the kidney, ureters, and bladder, KUB. So if the obstruction is pretty significant, if the LES is quite large, they're going to do gastric decompression. So they're going to put an NG tube in. They're going to allow the bowel to rest. The patient is going to be NPO. And they might be starting IV fluids with electrolyte replacement. It just depends on the severity of the client's case. They could be giving octreotide or sandostatin to help with the gut. And the additional diagnostics are going to be a CBC, and they're going to be looking at the chem panel to look for any dehydration. Of course, the x-ray is going to be done after we put this tube in, because part of the protocol for using an NG tube is to get an x-ray after placement, and it would show that the tube is in the stomach. So they could have multiple x-rays, one before to diagnose and one after to determine placement. And you're going to be assessing your bowel sounds. They're going to be hyperactive above the obstruction and hypoactive or absent below the obstruction. Frequent oral care, these patients aren't taking any fluids in. They've got this NG tube in. The mouth's going to get quite dry. Some physicians will allow a patient to have ice chips with the theory that it's just going to get suctioned out of the stomach anyway, but it's different for every patient. The octreotide is going to be to promote gastric motility. They're also going to take an H&H, look at the BUN, creatinine to determine dehydration, and they could be doing endoscopic, an upper GI, to determine the cause of the obstruction. And a CT scan can be done to determine the exact location of the obstruction as well. And just think about your care plans. What is going on with this patient? So they're not eating, but you don't just word it as client is not eating. You word it as lack of adequate nutritional intake prior to admission. So think about that when you're making your care plans. It's just worded a little bit different. So intestinal obstructions. This is different than an ileus. So here we have a mechanical obstruction. The colon could be physically blocked. The intestines can be physically blocked. And this accounts for 90% of all obstructions. The small intestine is more common, and usually these cases require surgery. So if you look at these, there's different causes of them. And when you're thinking about adhesions for mechanical obstructions, these can occur in patients that have had previous surgery. It's kind of scar tissue that's going to cause a blockage in that area. And intussusception, that is kind of like when you're closing a telescope, the bowel kind of closes in on itself. Sometimes you'll see a herniation where it's strangulated, and that would also require surgery. And then this one right here we don't see as often. So mechanical obstructions do occur due to processes outside the body like scar tissue or adhesions, or issues within the intestines like tumors or inflammatory bowel disease. This can be an obstruction pretty much anywhere, but like I said, it's more common in the small intestine. Other issues include encirclement or even compression of the colon. Think about tumors or endometriosis and strictures. The vulgus is the twisting, and that's this one right here, and hernias, which we mentioned already. There could be fecal impactions. Older adults are at risk for that. That can be partial or complete obstructions. There's really quite a lot of possibilities with these. So your manifestations are going to be dependent on the type of obstruction, the location, the level, the extent. There's a lot of things that go into that. So when the intestine becomes obstructed, gas and fluid accumulate. like what we talked about, to the proximal and within the obstructed segment. So that's going to really distend the bowel. So they're going to have pain with distension, vomiting, and when you think about vomiting or any type of bowel issues like vomiting, diarrhea, but in this case vomiting, you're going to have hypovolemia and probably an electrolyte imbalance. And just remember, location is everything. So the pain is going to start out, it's going to be colicky pain, and it's pretty mild initially, and then it's going to increase in severity. So you need to think about why that is happening. Is the obstruction getting larger? Is the fluid and food backing up? Are they still eating? There's a lot of things that can build into that. So when they do start vomiting, it can be just because of all the pressure. So think about that lady that was in the bed, and look how pregnant she looks. So when she's eating, that food has nowhere to go. If she keeps eating every meal, eventually it's going to back up to the point where she just starts vomiting. And again, hypovolemia, that's due to water and sodium. They're being drawn out of the proximal bowel lumen. Can also be because of the vomiting and lack of adequate intake. So they could have tachycardia, tachypnea, hypotension, and decreased urine output. So in the initial, like in the beginning, your bowel sounds are going to be somewhat hyperactive, and then it's going to go to hypoactive and then potentially absent, depending on how far this progresses. And it's going to be tender to palpation. So this is what I mean about location is everything, just like real estate, it's everything. So this patient's obstruction is right here. So you can see that everything is backing up, and they're going to have quite a bit of pain in this case. So their symptomology is going to be a little bit different than if they had an obstruction up here or down here. It just kind of depends on where it is. So just be open-minded to that when you're assessing your patient. Make sure that you're asking them about their bowels and doing a thorough exam on them. So treatment, they're going to have some GI decompression depending on the severity. Hopefully this person got an NG tube in, that's quite severe. So on the lesser severe cases, they might just make them NPO and give them some electrolytes and fluids. So decompression, this person here probably ended up with some surgery. If they do end up with an NG tube, you want to make sure that you maintain intermittent wall suction, and the order will say NG for decompression, and it'll say LIWS, low intermittent wall suction. So NG care, oral care frequently, make sure that maybe ask if the patient can have some ice chips, depending on the severity. Again, that patient we looked at earlier, probably not. So you're going to prep them for surgery. So again, consent, checklist, lots of different factors with that. Monitor their output. Going back to the NG tube, you want to make sure you irrigate that every 4 hours so it doesn't get obstructed itself, because sometimes what's coming out of it is pretty chunky, and you want to chart what's coming out of it. So you're measuring the output, you're measuring the consistency, the appearance, everything that you would normally document, you would make note of. Monitor the nasal area for skin breakdown. Offer oral care. Make sure the patient has sponges next to the bed. Assess their skin integrity, weight. Remember, the daily weights are a really good indicator of fluid volume status, INO, and then you want to make sure these patients are ambulating, so you would clamp the NG tube while they're ambulating. Other things that might be indicated other than surgery would be IV fluids. Remember, if these patients are losing fluids, they're also losing electrolytes. So for NG suctioning, if they've got an NG tube on and it's taking off volume, they're going to have an electrolyte disturbance. Medications for this patient, a couple different things we're going to be taking care of. So pain management, we want to make sure that we're taking care of their pain while being careful not to disrupt the gastric motility too much. So hopefully they're putting something on like Reglan for them to help with motility. They are going to have octreotide for treatment, that's the sandostatin for partial obstruction, and also broad-spectrum antibiotics. The broad-spectrum antibiotics are going to be based off of what's causing this issue and possible perforation, especially if they have an increase in their WBC count. So nursing diagnosis for this. So for fluid volume deficit, you're going to make sure that you're monitoring your vital signs frequently, manage the IV fluids, monitor urine output through strict INO, and of course your daily weights again. For ineffective tissue perfusion, monitor your vitals again, preferable pulses, INO, assess pain, and NPO until peristalsis returns. For ineffective breathing pattern, you're going to monitor respiratory rate, function, and lung sounds, ABGs if necessary, elevate the head of bed, splinting while coughing, and deep breathing, as well as good oral care. And then pain. We've talked a lot about pain with this one. Moving on to diverticular disease. So in diverticular disease, we have a small outpouching of the colon that occurs in rows. This forms when there's increased pressure within the bowel lumen, causing bowel mucosa to herniate through defects in the colon wall. So there's a lot of cultural factors such as a diet that are thought to play in the development. So the diet is high in refined sugar and fiber deficient foods. So that's thought to be the most contributing factor to this, as well as decreased activity levels and poor bowel habits. And you can see here an example of the diverticula. So diverticulosis indicates the presence of this diverticula. Usually it's asymptomatic and typically 2/3 of the population. So it's going to be about 1/3 of the population that's symptomatic. If they do have symptoms, it's episodic pain, usually left-sided, constipation, diarrhea. This is usually accompanied by IBS or irritable bowel syndrome, and they could have blood in the stool. As this progresses, abdominal cramping and narrow stools. If diverticula are formed, that's related to pressure in the bowel lumen, causing bowel mucosa to herniate. So diverticulitis, this is typically only one of those diverticula that has been affected. They collect undigested food and bacteria, forming a hard mass that impairs the blood supply, and ischemia can occur, which can lead to perforation. This is either causing steady or cramping pain, and the pain can be in the left lower quadrant, accompanied by nausea and tenderness. Objectively, they could have some vomiting, chills, fever, and tachycardia. They're going to receive antibiotics for the inflammation. That could be PO antibiotics if it's mild. Surgery can also be indicated if they have peritonitis or an abscess, or if hemorrhage occurs, and that's to remove the affected bowel. They also may temporarily need a colostomy. Diet can be used to manage diverticular disease. So you want to make sure that you're educating on a high fiber diet to increase stool bulk, decrease interluminal pressures, and reduce any spasms. High residual, so you're going to avoid foods with small seeds that can obstruct the diverticula, like popcorn and berries. NPL for severe cases, and avoid irritating the bowel, so limit fat to about 30% of the calories. You want to make sure that they're allowed some bowel rest as indicated during an acute episode. So laxatives are really avoided due to an increase in interluminal pressure in the colon and patients with diverticular disease. So they might be prescribed a stool softener instead. And then, of course, pain control. We want to make sure that we control their pain, so we want to offer them medications to help get through that. So with gastroenteritis, we have an inflammation of the stomach and the small intestines caused by a viral or a bacterial infection. So this is going to produce inflammation and tissue damage. So most of these pathogens enter through the GI tract by what we normally ingest. And sometimes we like to call that food poisoning, although it's really technically gastroenteritis. So the goal of care is to manage your manifestations, identify the cause, and prevent complications and prevent spread. So if it's a contagious pathogen, we want to prevent spread to your family. And these illnesses are generally mild and self-limiting. So it really depends on the symptomology that you have. So most of them are progressively unsevere unless you are very young, old, or immunocompromised. So that's your target that's going to be at risk. So your manifestations are going to be anorexia. Those patients don't want to eat, nausea and vomiting. They're going to have abdominal pain and cramping. You're going to have an increase in bowel sounds. They're going to be hyperactive. Diarrhea because of increased motility. Malaise, muscle aches, poor skin turgor, that's from dehydration. Orthostatic hypotension and tachycardia, also from dehydration. And then a fever. So treatment, most of the times these patients can manage their symptoms at home without ever seeking treatment. If it's more severe, they're going to need a stool culture if it doesn't resolve in about 48 hours to help diagnose the microorganism. And the goal of treatment is to manage the manifestations, prevent complications, and identify the cause. So you want to prevent spread. So if they are doing a stool culture, you want to make sure that the patient doesn't have any C. diff. If they do have C. diff, they need to be placed in contact isolation with gowns and gloves because that is an organism that spreads rather quickly. If they do have C. diff, you cannot give them antidiarrheal medication. You can treat them with Flagyl antibiotics or vancomycin orally. So you're going to use soap and water for your hands only. C. diff is not neutralized by hand sanitizer. So this is being found in healthy adults in the community right now. It is associated with antibiotic therapy. So antibiotics are going to interfere with the normal protective bacteria of the colon, and this leads to C. diff colonization. So the symptoms are going to be diarrhea, abdominal cramps, malaise, fever, and anorexia. And when I say diarrhea, it is quite intense. So these patients are going to likely be incontinent. So the treatment is by stopping the cause with the antibiotics. Hopefully, most physicians that are treating patients with IV antibiotics are also putting them on probiotic to help prevent that. And then, of course, Flagyl can be PO or IV, and the vancomycin can be given if it's resistant, and that is only going to be PO. It's been found that vancomycin given IV does not adequately treat C. diff. So some of the other new treatments they do actually it's not new, it's been around for a while, is a fecal microbial transplant, and that is when they do a transfer of stool from a healthy donor into the GI tract for purposes of treating the recurrent C. diff. So this is a lot of times done with patients that they've had multiple treatments and they just can't clear it up. So what they're going to do is they're going to try to get stool from somebody in the family, someone that lives in the same household. That way they have the same microorganisms in their GI tract. They're going to be bringing the stool specimen in. And what they're going to do is send that to lab. They're going to clean the stool, and they're going to make it into an enema. Or they could be doing this via colonoscopy. And they're going to be treating the patient, pre-treating them with oral vanco to help with this. So it has about an 80% success rate. So it's pretty effective in treating C. diff. So I'm not going to go over any of the parasitic information that's in your book, but just know that these are items that could possibly be showing up on your NCLEX exams. So really, ideally, you do need to know these. So we're going to talk a little bit about ulcerative colitis and Crohn's disease. So the etiology of both of these are unknown, but evidence suggests it could be due to genetic and environmental factors. Smoking and oral contraceptives do increase the risk. It is a chronic and recurrent disease. And about 3 million people in the United States are affected with this. So ulcerative colitis, this is mostly going to affect the colon and the rectum. Diarrhea and bloody stools are the predominant characteristic. Cause is unknown, but it does seem to be regional in the United States and Northern Europe and tends to run in families. And the attacks last from 1 to 3 months, and sometimes I've seen them more. Some of these patients are really badly affected by this. So this can occur in intervals, and sometimes it involves the entire colon and causes severe bloody diarrhea, abdominal pain, and fever. Most of the patients, fortunately, have mild to moderate disease as opposed to that, but you're wanting to look for 6 stools of less a day. And you can see how inflamed this looks here. So sometimes these patients can get abscesses. So the abscess can cause necrosis. Then the mucosa is red and edematous due to vascular congestion, and it's very friable. So that can ulcerate and easily bleed. Chronic inflammation can cause atrophy and narrowing of the colon, and that can lose its function to help move stool. So the complications of this can be a manifestation of toxic megacolon, and that is a condition characterized by acute motor paralysis and dilation of the colon to greater than 6 centimeters, so it's quite large. Other manifestations of this can be fever, tachycardia, hypotension, dehydration, and abdominal tenderness. They can have cramping in the left lower quadrant, a change in the number of stools a day, fever, mucus, or pus may be present, and high-pitched bowel sounds. Think about all the blood loss that these patients are experiencing. So think about anemia, hypovolemia. They probably also aren't eating very well, so malnutrition. They're going to have some stool urgency, weakness, abdominal cramping, and fatigue. So Crohn's disease, this is chronic relapsing inflammatory disorder that affects the GI tract. This can be both in the large and the small intestine. And the symptoms are persistent diarrhea for 5 stools a day, pain in the right lower quadrant, fatigue, malaise, weight loss, and they can have anemia. They can also have rectal lesions, fissures, ulcers, fistulas, and abscesses. And then there's no obvious blood or mucus in the stool for Crohn's disease. So complications from Crohn's disease, they could end up with an obstruction, an abscess, or a fistula. These can begin as small inflammatory lesions of the mucosa and submucosal bowel. The inflammatory process eventually involves the entire small bowel wall, or the wall of the bowel appears as a cobblestone. So if you look at this, it kind of looks like cobblestones in there. Complications are common, so they're considered part of the disease process by some. So that means that these patients are probably definitely going to have complications from the disease. They could have obstructions due to repeated inflammation and scarring of the bowel. Think about the adhesions we've already talked about, and a fistula between the bowel and the bladder. I've seen some people, too, that will have fistulas between the bowel and the vagina, so it can be quite severe. Symptoms include loose stools, abdominal pain, tenderness, fatigue, and weight loss. So your treatment, you want to be supportive to decrease inflammation, promote intestinal rest and healing, and promote intestinal motility. So the main goal of care is to achieve and maintain remission of the disease and its symptoms. So malnutrition and malabsorption may develop as the ulcers prevent absorption of nutrients. There's a lot of drug therapies out there that play an important role in achieving remission. So meds have a lot of anti-inflammatory primary medications that are used to relieve or manage mild to moderate disease, and that can be in immunotherapy. So they could be also using corticosteroids to reduce inflammation and induce remission. And think about all the effects that those patients can have from steroids. They might be giving Flagyl. So that is not typically indicated unless it's severe. And Flagyl has some active anti-inflammatory agents. Anti-diarrheal medication like loperamide or Imodium to slow gastric motility, and that can help reduce diarrhea. They could be doing Remicade to suppress the immune system. And sometimes they're going to be NPO with TPN to rest the colon. I have seen some of these patients with severe cases end up with ostomies. So surgery would be only if necessary. It depends on the amount of affected area or if there is a bowel obstruction. So really you want to decrease complications with this. Malabsorption syndrome. So this is a chronic immune disorder of the small intestine in which absorption of nutrients, and it's particularly fats, are going to be impaired. So celiac sprue or celiac disease is going to be a chronic condition that often develops in childhood with T-cell autoimmune genetic disorder of the small intestine. And that's where the absorption of nutrients, particularly fats, is impaired. So they can have a sensitivity to gluten, and this can be genetically linked. One of my son's friends, their whole family was gluten intolerant except for the dad. So it can really be genetic. So it can cause excess fat in stools, anemia. Think about nutritional deficiencies. And when gluten is removed from the diet, a lot of times these symptoms resolve. But it can be quite hard to eliminate gluten from diets, and it's expensive, very expensive. So to diagnose this, they're going to do an enteroscopy, which that examines the intestinal mucosa, and they're going to collect tissues for a specimen for biopsy. They might do some genetic testing as well, and then for treatment, they're going to implement that gluten-free diet. That's usually the most successful as long as the patient avoids gluten totally. So gluten is widely used in a lot of prepared foods, and typically the diet is high in calories and protein to correct any nutritional deficiencies. So they really want to avoid that gluten and have high calories and high protein. So you want to get them in contact with a dietitian. That can be really helpful. Some of the grocery stores do have dietitians there Monday through Friday, so that can be helpful as well. But it is really hard to find any type of gluten-free diet, and especially if you're thinking about children that like their pizza and their macaroni and cheese, it can be quite a challenge for them. They do have products out there, but they're typically just high in cost. So tropical sprue, the symptoms and pathological appearance of this is going to be similar to what you see in celiac disease, but it's not an autoimmune condition, and it's considered most likely to be an infective one. So the causative agent, however, is really unclear, although it's suspected to be bacterial. Tropical sprue is often seen in residents of or visitors to tropical areas, and tends to begin with an acute episode of diarrhea, fever, and malaise. And that's prior to setting into a more chronic presentation of malabsorption, nutritional deficiency, anorexia, malaise, and weight loss. There's going to be a folate deficiency, and that's a significant part of the clinical picture. Diarrhea with this is usually initially explosive and watery, and then as the disease progresses, the stools become fewer in number and more solid. So they're also going to have dry, rough skin, stomatitis, and glossitis. And the systemic manifestations of this are going to be due to malabsorption. So with malabsorption, you really want to identify the cause. Is it going to be a gluten as a causative factor or something else? So you really want to encourage vitamins and supplements. These patients need to have those items replaced. If it's celiac, initiate a gluten-free diet and provide lots of education and get a dietary consult. So diagnostics can be an upper GI series, barium swallows, and barium's going to clump together with celiac disease in the small intestines. So that's another way they can diagnose it. So another issue could be lactose intolerance, and that's due to lactase deficiency. So sometimes these patients need to be placed on a lactose-free diet. We are going to skip over hemorrhoids. That's something that unfortunately is very common in people, but it's something you could read on your own. just make sure that you're aware of it, and I'll post this PowerPoint. Same with this one too. So go ahead and read that on your own, but we won't go over it in detail in lecture. As with this one's pretty rare. So with colon polyps, you're going to see a mass of tissue, and that arises from the bowel wall and protrudes into the lumen. So this is going to be a disruption of the normal proliferation of epithelial cells, and this may develop in any portion of the bowel, although it's most often occurring in the sigmoid colon and the rectum. There can be single, or there can be multiple, and some of them are going to be quite large. About 30% of the people over 50 are going to have polyps. And one of the videos that I'm going to post a little bit later, you'll be able to see some polyps being removed. So diagnosis of intestinal polyps is generally based off of diagnostic studies such as a sigmoidoscopy or a colonoscopy. So the rectal polyp might actually be palpable on a digital exam, but usually when they find these, they're going to want to do a further study to determine the size and probably remove it and do a biopsy. Intestinal polyps are going to affect men and women equally, and they increase with age. So because polyps tend to reoccur, follow-up colonoscopies are recommended in 3 years and then in 5 years, and if no further polyps are detected. And this is really going to depend on your patient. If they have a strong family history of colon cancer, they're going to be doing screening more often. So tests that find polyps and cancer, they're going to do a flexible sigmoidoscopy every 5 years, a colonoscopy every 10, and then a double contrast barium enema every 5 years. They could be doing a CT colonography with a virtual colonoscopy every 5 years, and the tests that mainly find cancer are going to be looking for fecal occult blood. There's some genetic screenings they can do in the stool, fecal immunochemical test, that's a FIT test, and a stool in the DNA every 3 years. And again, it's going to strongly depend on the patient's status, their family history. So here's a good picture of what happens to a polyp after it turns cancerous. So early diagnosis of this and improved treatment have really improved the survival rate for colorectal cancer. So early diagnosis and treatment, then the 5-year survival rate for colon cancer is about 90%. However, it's only about 39% of colorectal cancers are diagnosed at an early stage. And this is what I'm talking about when I say an early stage. So your risk factors for this are going to be anyone over the age of 50. So polyps of the colon and rectum are going to increase your chances of this occurring. Family history of inflammatory bowel disease, exposure to radiation, and a diet high in animal fat. So think about the kind of foods that we eat in the United States. So the specific cause is unknown, although all of those items I mentioned are risk factors. So nearly all adenocarcinomas begin as these polyps, and many develop in the sigmoid colon and the rectum. So the typical tumor is going to grow undetected and produces very few manifestations. That's why a lot of times they go undiagnosed until they're quite large. So by the time the manifestations occur, the disease may have potentially spread into the deeper layers of the bowel and in adjacent tissues. So some of these manifestations can occur at 5 to 15 years of growth before the patient notices anything different with their body. So they often don't have any symptoms until they're advanced. They could have some rectal bleeding, a change in bowel habits, maybe some pain, but all of that happens much later. Anorexia, weight loss, and anemia. So the best thing that we can do with colon cancer is to prevent it. So we want early screening, we want prevention, we want detection. So prevention, reducing the risk through diet high in fruits and vegetables and low in saturated fats and red meat. So we also want to encourage exercise, vitamins, maintaining a healthy weight, limit alcohol consumption, quit smoking, consuming high fiber supplements, increasing calcium, And then daily use of aspirin and NSAIDs has been shown to help prevent colon cancer. And then screening interventions, very important. So we're going to advise all of our clients to be screened for colorectal cancer at the age of 50, and the gold standard is really going to be your colonoscopy. So the American Cancer Society recommends a yearly fecal occult blood test. They're looking for blood in the stool, a sigmoidoscopy every 5 years, and a colonoscopy every 10. If they do other tests, they could do contrast barium enema, a CT colonography, a CBC to look for anemia, and that's going to be due to bleeding. And that's it for those. So let's see here. So we want to really educate our patients on early screening and early interventions. So colonoscopy, they're going to be doing some screening here, and this video shows two different ones. So this one up here, the Jimmy Kimmel one, is kind of funny and educational, but the Dr. Gray one, he's a really talented and skilled gastroenterologist. So I would, if you're curious about what happens during a colonoscopy, I would watch this one, and that'll be posted online for you to see. So treatment for colon cancer is going to be surgery, chemotherapy, and radiation. And you can see that is quite a large tumor there. In your nursing diagnosis, they're going to have some pain, so you want to treat the pain. They have impaired nutrition, less than body requirements. You want to get dietary involved, dietitians involved. Anticipatory grieving, these patients, again, their diagnosis has been made pretty late in the process. They're going to have some grieving associated with that. And risk for sexual dysfunction. Think about where this area is located. They could end up with an ostomy. There's a lot of things that are going on in their minds about this. So surgical procedures for the bowel, we could have a colectomy, a colostomy, or an ileostomy. So a colectomy, this can happen with clients with ulcerative colitis, and they may require a total colectomy. So surgical resection happens and removal of the colon. And this surgical resection of the bowel may be accompanied by a temporary ileostomy for about 8 to 12 weeks. If the patient complains of gas pains or abdominal distension, get them up and walk them. And you want to think about why that happens, because you want to increase peristalsis and decrease flatus and gas pains. So ostomies, the precise name of the ostomy depends on the location of the stoma. So the stoma can be in any one of these places. So ileostomy is going to be made from the small intestine. So if you're looking at the different options on, well, actually this one doesn't have a picture of it, but the small intestine is going to be right there. So ileostomy is made from the small intestine, and a colostomy is made from the large intestine. So that's going to be a surgically created opening between the intestine and the abdominal wall that allows for passage of fecal material. So depending on the severity of a patient's disease, it might determine how significant the surgery is. So sometimes it's minor and sometimes it's pretty major. Like this person right here, they got to keep most of their large intestine and they only removed the sigmoid. So it just depends. This one lost the whole thing. And the amount of stool and the characteristics of the stool is going to change based off where that ostomy is located. You can see the different options here. And I thought this was interesting because this is how they create an ostomy. So they're going to pull the intestine through, and the same thing applies for a colostomy here. So they're going to pull the small intestine through for the ileostomy, flip it back on itself, and sew. And this is one of the reasons why they all look just a little bit different. Plus, it also depends on the placement of it. So if it's placed in a different area, it's going to look a little bit different. So with our assessments on our ostomy, you're going to assess the peristomal skin, and all of this you're going to make sure that you are document. documenting. You're going to assess the stoma. I've seen some as big as a thumb and some that are really tiny. So you want to make sure that you're assessing the skin on the stoma. Make sure that it's intact. You don't want it to be irritated around the peristomal skin. If it is, there's things you can do to help with that. You're going to assess the output, the color, and consistency. Just remember, like the higher up it is in the intestine, the more liquid you're going to want it to be so that it doesn't get obstructed. The stoma should be pink and beefy, red and moist, and they say about 2 centimeter protrusion, but again, I've seen some that are quite large. You want to measure the INO. So initially they could have dark green on their stool, and that should eventually turn to a yellow or brown depending on where it is. And sometimes these patients do get constipated, so if you have no output, you want to make sure that you let the physician know that, and they might even need a laxative. So report any abnormalities, any bulging around the stoma or bleeding. They could have a herniation. You're going to be educating your patient on how to empty the pouch, how to apply it, how to change the dressing. At Unity Point, we've got a wound care team that is really good. They actually talk with the patient before the surgery. They come in and talk to them about ostomies. They're in the surgical suite helping the surgeon look at the patient's anatomy and find the best place to place the appliance. That way it adheres to the skin properly. So they're going to really be doing a lot of education on that, but you need to help support that patient through that. So low fiber diet, depending on where that ostomy is located, and really provide support for these patients because of body image. Some of them have quite a different view of themselves after this happens. So with an ileostomy, the ostomy is made of the ileum and the small intestine. Those are going to be always liquid. So if it's too firm, you really need to be contacting the doctor. It is very corrosive to the skin, so if they are leaking, if these ostomies, the ileostomies are leaking, you need to make sure that you clean the skin and change that appliance right away. Low residual diet, no whole grains for them. So ostomy care, you want to get the wound care team involved, although they will automatically be seeing this patient at UPH. And one last thing I just wanted to share with you. So these are people that have ostomies for a variety of reasons. Some of them have Crohn's disease, some of them had ulcerative colitis, some of them have cancer, some of them were born with birth defects. So I just wanted you to see this. So a lot of people I've taken care of, I can tell you a lot of stories about patients that really view themselves differently after having an ostomy. They're embarrassed, they think it smells, they think it's ugly, they're afraid to wear a swimsuit, and just share with them that they can move on from this. Sometimes these are reversible, but sometimes they're permanent. But there are people from all walks of life. This lady right here, she does a lot on body positive image, and she makes ostomy covers. So they're custom ostomy covers, and she'll make them for just about anybody. So just because you have an ostomy doesn't mean your life's over. You can still have babies. You can still move on and do just about anything. This person right here is a fitness model, as is this one. This one's a marathon runner, so it really doesn't limit what you can do in life. You just have to make some adaptations to it. So if you have any questions, reach out to me, post on the discussion board, and have a great day.